anatomy, physiology, and patho of geriatric, of peds, of OB, obesity, every population. This is what they want you to know. They want you to know A&P and patho. They want you to be able to discuss pharmacology related to that patient population, special anesthesia techniques and implications, and how we're going to manage them, regardless of the population. So really, these are the course objectives in a general sense for the entire semester. But today, we're going to talk about geriatric folks. I like it. Usually the definition is 65. Yep. The main thing about this is that this population is growing more and more and more and more, so you're going to be taking care of more and more of them. That's the main thing. So 2030, 80 million Americans will be elderly. And what's important here, 50% of healthcare expenditures are going to go on that population. If I'm alive then, I'm hoping I don't have to have your services, but if I do, I will expect you to take very good care of me. 50% of the people that are 65 will require some kind of surgery before they die. And I know you've already looked at the slide, so what kind of surgeries will we probably see? Hips and eyes. Hips, cataracts, eyes. Turks, so prostate issues, hernias. And I had a day of hernias yesterday. And black colors. All that goes fast. All right. Those are some of the most common. You're going to get really good at it. Now, life in terms of expectancy, I would have been dead in 1900. But now, this only went up to 2000, but now I think it's like 82, 83. Women have a couple more years on guys. But we're enjoying the freedoms of living lives more parallel with how men live traditionally. So we're getting some of the same problems in dying sooner. So it's kind of like balancing out. The cost of freedom. All right. A long day for me too. Okay, so these are the things you're going to see, and you're going to have to change your anesthesia plan based on not only just the process of aging. Like aging healthily and normally is going to change, and it's going to affect how people respond to anesthesia. But along with that, with age, these other things happen to us: heart disease, arthritis, impaired vision, diabetes, CV problems, COPD. So wow, all of those things it are going to make your anesthetic plan a lot more challenging. Yeah, I had a guy with inguinal hernia repair, incisional hernia repair, that was large BMI, all kinds of comorbidities. And when he laid flat on the table, like when you just saw him, you didn't see the hernia. When he laid flat on the table, it was like, and he was really like that. And I'm like, I'm glad he's here to get this taken care of. He had like he did have COPD, he did have diabetes, did have a history of a stroke, he did have a cabbage in 2017. I didn't ask him how well he could see. I did ask him to take his glasses off though. I had to think about a lot of things. What was I going to do? How was I going to help him? How was I going to get him through this safely? And so one of the things, he was probably, I'm going to say 82 years old. What would you think about the first part of my anesthesia plan? The first thing I introduced myself, talk to him about the plan, get consent. When I think about going back and start thinking about pharmacology, what would you consider with a guy like this?
RSI. No benzos.
Well, the question is, will I give this guy Versed or not? Will I? Maybe yes, maybe no. If I do, how much am I going to give him? Am I going to give him 1 milligram low dose? Am I going to give him 2? Then the question comes up like, do you drink? A little bit. Quit smoking a couple years ago. Oh, I quit smoking in 2016 when I had my 4 cabbage. Okay, so we're good. So we had that going for him because he stopped smoking for at least a year or so. So that was good news. Do you think his mentation totally with it? Good, nice guy. Sweet guy. Didn't have any problems with dementia, didn't take any very, very limited alcohol, but he was nervous, and I said, well, before we go back, would you like something to help you relax? He said, I think I would. Okay, so I really wasn't worried if I gave him 1 milligram that he was going to crash and have an MI. You know, I really wasn't too worried. So I wouldn't automatically assume no benzos. Now I might, but I did not. After talking with him, he had a pretty good exercise tolerance, which amazed me. And he did have his bypasses done, so I know his heart was getting what it needed, I'm hoping. And his diabetes was managed, and he didn't have any residual related to any other real issues. He stopped smoking. He didn't have to use his inhaler hardly ever, and his lungs sounded good, and blah, blah, blah. So I gave him one of her set, and it was perfect. It made him happy, and it made me happy. Of the things we're going to perform, make sure you know these. There might be others, but a lot of folks, you may have already seen. How many of you have done eyes before doing an observation or in the area? So eyes are done differently at different places. So some places just do topical numbing. The nurses just put the drops in, and then when they get ready, then they just do it. You just observe vital signs, basically. Make sure their blood, make sure they're hemodynamically stable. And then other places they do retrobulbar blocks, and sometimes the anesthesia do it, and sometimes the eye surgeon does it. Just depends where you go. I've never done one, and I've seen plenty of them done. I can be trained to do them, but I'm okay not to stick the needle near someone's eyes if they think I'm going to do that. But you may have a chance to learn those. If you do have a chance, jump on it, because a lot of places don't do it. A lot of us, we don't get to do them, so if we had a chance to learn them, I would definitely do it. This is sort of depressing, that there's an increased mortality, a really big increased mortality over the age of 70. However, the good news for me is that only 2% contributed to anesthesia. But when you compare the risk, 2% if you're 70 or older, compared to our normal risk is pretty high. But still 2%, not so bad compared to 300, right? Not too bad. When people that are older die in the OR, basically, their anesthesia risk is typically it's like a DVT type thing, whether it's in the head or the heart or the lung or an MI. That's what I've seen most. Sepsis is something that develops over time, and it's usually something that happens after the fact, where they already come to you septic. It's not something that usually may happen in 2 hours or 3 years I do it, right? But mortality related to anesthesia, sepsis after the fact. The MI, you would see an intra-op. What might be some things you would see on the monitor that might think it's an MI? ST elevation. What if it's ST depression?
Look at the contralateral lead as well.
So when you look at an EKG, then what leads you going to look at? For?
So 2 and 5.
Eventually you'll get there. So the other little set of slides I had in there were done, I think Dr. McDonough, I've been involved in a lecture, and then somebody at Mayo did this lecture. And so I have these slides. They kind of go over some EKG basics. I just put them in there for your edification, just to remind you of some things you probably already know, because all of you had to take telemetry classes years ago, and you all had to do this, and now you're looking at it from an anesthesia point of view. But I just thought both the lung PowerPoints and the EKG were kind of nice and concise and would be a good review for you, okay, as you're going out and doing your assessments. That's what that's for. But if you're in the OR and you see you see the fireman's hat, remember that? Call for help. If that were happening, and you had someone that had a change in their EKG, well, when you're monitoring them and you have a change, and you see ST elevation, what might you do? What do you think you might do?
Nitro, if it's in the cart.
Maybe you might do nitro.
Get the heart rate down, myocardial oxygen.
You tell the surgeon you're going to call for help. Either your CRNA get back in the room, urologist get back in the room. So you're going to call for help. You're going to let the surgeon know. You're probably going to give some metoprolol, typically.
Sure. Heart rate down.
Yep.
Maybe get some more O's. Turn up the oxygen.
Probably put them on 100% O2,
yeah.
Probably.
And then,
they probably have already been narcotized. I mean,
sure.
They probably already have given some opioids, so normally you might think like ICU, you probably give them some morphine, right?
Right.
Morphine and nitro.
Right.
So it depends. What are you going to see on the monitor if you suspect someone's got a throat clot somewhere?
Ooh.
What are you going to see? It does depend. If it went in your brain, are you going to see it right away, you think? Probably not, so have you. Right? Okay, so we're gonna eliminate that one for now. What else might you? It might go, if it doesn't go to their head, where might it go?
Lungs.
Okay, if it goes in the lungs, is that something you might be able to detect? What would you see on the
Sort of.
Okay, so entitled capnography is going to be off. What about CO2 or O2?
Yeah, desaturation.
So they're probably going to desat. What's going to happen to their CO2? Why? Because
losing all that real estate.
so the CO2 is building, but it's not getting out, right? You can't blow it off. It's not going away, so it's building up in the bloodstream. The oxygen's not being circulated to it. So now the lung problem then becomes eventually a heart problem because the heart's getting not the oxygen it needs, so it gets ischemic too. I see respiratory and cardiac failure in this scenario. Now, the sooner you notice EKG changes, the sooner you notice maybe some of these unexpected changes in O2 saturation, entitled CO2. You want to look at that. Sometimes you're just over or under ventilating, and they're not having a clot. It's not what you think, but you need to troubleshoot to see. You all of a sudden you look over at the vent, and you've got them on, respirations of 16, and you've got 650 on the tidal volume. Like, no wonder things are different. Or you might have, 7 breaths and 450 volume, and then their end tidal is like way high. Well, then have increase the respiratory rate, increase the tidal volume, get that CO2 down. Okay, that was an easy fix. It wasn't really what I thought it should be. All right, what happens? Anatomy and physiology. This is really depressing, but for you as a person that's assessing your patient, you come across a patient you're going to take care of, and they're older, they're elderly. Now, the things that are going on with them, is it because of the aging process? Is it because of the coexisting disease they have? And sometimes you can't tell the difference, and sometimes they just work they work together against you. So normal things that happen during aging, we'll talk about that. And then when you add these other comorbidities, it's going to even change your anesthetic plan even more. So as you're developing your care plans, you need to think about some of these things. So overall, your cardiovascular changing, there's a decreased response in the autonomic nervous system. And another big problem is the heart can't really compensate in an older person the same way as a younger person. It can't compensate both high and low heart rates. So if it goes really, really low or really, really high, typically it can't. So when they start exercising, it goes up and it goes up and it goes up and it goes up, and then it takes it might take 3 minutes or 5 minutes or less for your heart rate to go down if you had maximal heart rate when you're working out. But then it might stay up and it might stay up, and it's like you gave them, Robenol or something, and you're like, this stays up and it stays up and it stays up. They just don't handle extremes of stress very well. It takes them a while to compensate, and sometimes they don't ever compensate. So they can't compensate for surgical stress as well as a younger person, because reserve, cardiovascularly and respiratory in almost every way, it's decreased. So it's just reduced everywhere. Now you know about cardiac output. It equals stroke volume times heart rate. That output decreases with age. And there's, unfortunately, a linear relationship. Oh. So, question?
No.
Okay.
There's no cards for you.
Okay.
Wow.
Thanks. Just for me guys.
You're the bomb.
Yeah.
Are you in your little cubicle studying?
No, I don't have a beard.
Oh, perfect.
No.
Thank you. You're welcome. Sorry.
That's an honest answer. Okay. All right, let's see. What do I want to say? 20%, your heart rate increases by 20% by age 75 when compared to a 20-year-old. What? Maximum heart rate. your conduction time is slowed. Everything is pretty much, in a lot of ways, reduced. Now, there are some, we'll look at some slides where you have some things increase, something decrease. I would make sure you know those, what increases, what decreases. But overall, if you're going to make a general statement, we would say things tend to slow down. And it's, older people don't compensate as well for the different stresses of living and exercise and the stress of surgery, and most functions are reduced. The important thing about heart rate and cardiac output is that your circulation time is going to be increased. And when you're starting out, and you're going to, either you or whoever you're working with, you're going to be pushing these drugs, and you're going to be ready to go, because even 10 seconds feel like a long time when everybody's waiting for you to do the intubation, but you're waiting for the circulation, the drug to get circulated through the body, and sometimes it takes a while. It might take a minute. It might take a minute and a half. It might take 2 minutes, and that will be the longest 2 minutes of your life, because you're just nervous, and you just want to put the tube in the hole. Yeah.
So,
Trust me.
I was wondering this whenever I was reading through. In elderly patients, would it be smarter to use a volatile anesthetic agent to induce, because the slowed circulation time would actually increase their rate of the take-up of the
It's not a bad thought, but it's not usually done in practice. Not a bad thought.
Well, and then the other article that we had to read talked about the cognitive impairments, but it also talks about there's no real study that says that it's.
So this has been a, since I've been around in anesthesia, this is the argument. Traditionally, people thought, when we have an older person, let's do regional. At all costs, we're going to do regional, because we don't want to do general anesthesia. We want to stay away from the gap. Sorry, Dr. McGinn. Because I know that's his philosophy with everybody. So far, there are some studies that indicate one's better than the other, but overall, the consensus is one technique is not better than another for a general population. But there might be certain patients that regional anesthesia would be much better for. Epidural spinals might be much better than that, than doing general. I'm going to see. I always recommend doing ERAS protocols where you can, and when or TIVA whenever you can. But even that has, for older folks, they still have responses. So no matter what technique you use, you're going to find issues and problems. So if I did I go, oh, we're going to do a total knee, and we'll do a spinal. So maybe maybe they had something going on and it was hard to do a spinal. Maybe not. Maybe they're not a candidate for a spinal. Well, I can't do a spinal because they have scoliosis, or they've got plates there, or whatever.
Positioning issues.
Yeah, they've got kyphosis. I mean, whatever. And so you're like, oh, well, I can't, even though that might be what I prefer, because they have all these comorbidities, what am I going to do? So what I have found is, this is not always true, but for most patients, and even most procedures for elderly folks, you could probably do either technique, and either one would be fine, but you've got to be considering of all the possible factors, and everything is going to be gentler and slower and take more time. It's going to take more time to go to sleep. It's going to take more time to wear down. The doses will probably be different, and for the most part, they're going to be reducing MAC values and drugs. For the most part, there are some that don't really make a difference, but for the most part. But I wanted to have both of those articles in there. They're both kind of old, one's 10 or 12 years old. But I thought they had some good points. And it also helps you see that as we come up with information, there's not always a black and white. Like, you want it to be this way only, or this way, but it's not. It's so much gray. It does depend. Depends on a lot of different factors. Depends on what anesthesia plan are we going to use, what surgery are they having done, what other comorbidities that they have, what can they tolerate, what's their preference. I don't think I've ever done an inhalational induction on an elderly patient. I've done it, of course, with peds. I've done it with adults, but I don't think I've ever done it. But you might not be a bad idea. But I'm always thinking that when I use gas, what's going to happen to the blood pressure? It's going to drop. If I induce with propofol, what's going to happen? their blood pressure's gonna. So when I work with elderly folks, I use a lower dose, and I actually take longer for it. I push it over a longer period of time, and I let it develop, and I let it sit up, and I talk to the patient, and you're waiting, And then something else I do is I let the staff know that who I'm working with, that work with me every day, and know me and how I do stuff. I just say, this next person's, 95 years old, and so I'm gonna do a real slow induction, we're gonna do a real slow wake up, so just so you know. Okay, so don't be rushing me. I just tell them right up front. Because normally, like, I'm in, I'm out, I do my thing, and they're like, we like her, this is something, okay. But with this patient, 95, we're gonna take our time. And they go, okay. They know ahead of time, they know I don't usually do that, I'm not trying to delay the day, we all wanna go home. However, I wanna take really good care of this patient. Sometimes it's gonna take longer. But being patient for this circulation, increased circulation time, will not be easy for you. I know it won't. In the meantime, your CRNA might be getting start asking you every question under the book. While the circulation time is occurring, and you're thinking, I'm just focusing on, can't I just focus on the intubation? Can't I just focus, because you want to do the task, right? You want to do the one task, you're focused on that, and they might ask you something about the respiratory physiology of the lungs. Thank you, Dr. Wilver, I remember that. And I said, Dr. Wilver, I'd like to talk with you about that, but right now I just need to focus on the intubation. He's like, oh, it didn't occur to him. It didn't occur to him, oh, right now I just need to focus on the intubation. He's like, oh yeah, I've probably done 3, I need to just focus on this one task. We can talk about the respiratory physiology of the lungs later, maybe. I still wouldn't be able to answer his question. But not right now, I need to do this task. What happens with blood pressure? It goes up. It's normal to go up. So up to 150 is kind of not too abnormal for someone that's an elderly patient. So what I say about that is you want to keep it within what percent?
20%.
Now this will be a problem when you work with orthopedic surgeons. And those of you that have had some experience know what I mean by that. They're going to want, I want the systolic blood pressure 100. But man, we're certain. This person lives at 150 systolic. I would be glad to try to bring it down to maybe 125, maybe 120. But I need to keep the mean arterial pressure, and you name the number. What would be a reasonable one?
70.
65,
Yeah.
70, okay? Because I want to keep their head and their heart and their lungs and their kidneys perfused to keep this patient alive so they can appreciate the great joint replacement you've just done for them. Okay. If I have that conversation ahead of time with my surgeon, it usually works real well. Now, I can't do that for every patient. They will call me out on that. But when I have someone I'm truly concerned about their blood pressure and someone that's aged, I'm going to have that conversation with them and say, just so you know, their blood pressure was this when they came in. I'm going to keep them as low as I can to keep everything in their brain, their heart, their lung, their kidneys perfused. Okay?
Okay.
But if I've had that conversation, when they look up at the monitor, and they will understand that their normal is 150 and I'm keeping it 125, and that's the best I'm going to do. Because I want reduced blood too. I don't want them to have a lot of blood loss, because I don't want to have to replace it. That's more work. Oh, I didn't mean that way. But I think that's going to be something that you will encounter for your bless you. It wouldn't really be your battle as an sRNA to fight that battle with the surgeon. There would be a question to ask your CRNA. This person comes with high blood pressure, and for them, this is their controlled pressure parameters. Would it be appropriate to keep this person within 20%, even though the surgeon's asking us to have 100 systolic? And you and that CRNA have that discussion. And then you work it out between you, and the CRNA and the surgeon will have these discussions. Or in some cases, I have to have the anesthesiologist and the surgeon have a discussion, because I've already tried to have that discussion, and it went over the surgeons. So I said, I call my supervisor, hey, would you mind coming in and have a telephone? to have a better day. Because I am just trying to take good care of my patient. That's all I want. All right, the effects of stress and exercise. What happens? We have a decrease in the baroreceptor reflex. So they go from a lying and sitting position, and what happens? Postural hypotension, and they can pass out. Now you know that from seniors, right? You ever just like get someone up, like, just give them that, let's go.
back to bed. Back to bed.
It happens. It happens. All right. Some things that happen to your heart. The muscle gets thicker, the endometrium gets thicker, sometimes the left side gets bigger, it's not as efficient, the valves get calcified. Ooh, it's just all kinds of things change, and so you kind of have to change what you do based on what you see, what they tell you. What's the patient telling you? It's based on their heart rate and their blood pressure and all that stuff that's going on in the vital signs. You want to watch it. They have higher filling pressures. Those are needed because it takes them longer to squeeze the heart and it takes them longer to relax. They don't have, if their heart rate goes up, they just don't have a tolerance to handle that heart going that fast. And the problem for us is it increases their chance of an MI. So if you have an elderly patient and they get tachycardic, it's something you do not want to let continue on. You probably are going to give them something to bring it down pretty quickly. Any ideas?
Esmolol.
Esmolol? What would be a reasonable dose, you think? 5 milligrams probably won't do too much. But I'd say that's reasonable.
That's like 100.
10 milligrams might be reasonable. 20 milligrams might be reasonable. If it's 150, I'm probably going to use 25 to 30. And I want to go, okay, too much. What I mean they can't hang, what I mean is they go from that to slow, or they go so fast and then it starts quivering, and then now we're in ACLS protocol, so make sure you brush up on those too. You need those. So again, we talked about thick heart, everything gets thicker. We talked about calcification, and what that's going to do is when you listen and you auscultate the heart, you're going to hear more murmurs. There's going to be stenosis, there's going to be insufficiency, and you know there's the aorta valve, mitral valve, all of those. And there are specific sounds of each one. It's okay to listen to those and learn those. I have found with in my normal anesthesia pre-op assessment, I hear a murmur or I don't. They can say I have a murmur and I listen to those crappy little stethoscopes they have. Or one of my nicer ones, like maybe I hear a murmur. I'm not going to diagnose it. Now, if I walk up to them and I hear a murmur, I'm like, oh, okay. Did you know about that? No. You ever feel fluttering? Yeah. Maybe we need to get a cardiac consultation here before we go back. Okay. But typically, these things are going to be happening. They're probably already diagnosed because a lot of times your facilities will require at least for someone older an EKG, a pre-op EKG. It gives you a baseline. Some places won't require that, but many of them will. Someone's 65, 70 years old, they'll require an EKG. So you have a baseline, and then when you get ready to go back and you see them on the monitor and it's different, then you might want to get an intra-op, or you might want to get an EKG post-operatively. But if they have one ahead of time, you will have something to at least compare to. But the EKG is really only as good as the moment it was taken, right? But it can tell you something's going on right then, right? So you're looking at the different leads and trying to decide, is there ST depression? Was there ischemia? And if there is, did they get worked up? Did they see cardiology related to this abnormal EKG? If they did, they'll have a stress test, they'll have an echo, you can look at that. One of the most important things I want to know is what's their ejection fraction? What am I hoping for? 55, 60, 70, When I get one down to 20 or 30, I'm starting to go, oh. So we're going to go to sleep? Maybe a spinal would be better for this guy, But even those, what happens when you do regional, when you do a spinal and epidural? Can the blood pressure drop? What am I going to do? Well, I can load them up with crystalloid, but they can't take a big shift in that either. You can't give them anything too fast. First of all, it takes a while to get there, but you can't do anything too much too quickly. It's stress on them. So either way, you is that most older folks know that they have some kind of cardiovascular disease. And if something is, if they come in and they go, you know, I'm having chest pain. Okay, maybe anxiety, but it's not, you don't decide that. What's it like? When did it start? What's going on? They may have to have cardiology see them and then go straight to the cath lab before we do anything, think about any kind of surgery. There will be changes in the heart. These pacemaker cells, they're decreased. And there's sclerosis of the conduction system. All this is sounding really depressing to me. I'm going to go run when I get home. But the importance of these two things is that it increases the risk of heart block. Now, first degree heart block probably is benign, right? Yes? No?
Yeah.
So second degree, we have two types, right? One is leaky back, and what's the other one? Okay, so leaky back, well, let me say this. Which one is the one that gets the PRN or gets one?
Winky Bach.
You're sure?
Yeah. Yeah.
And so the other one, it's prolonged, right? But it stays the same. So you can recognize that pretty easily on the EKG, right? You can recognize the difference between an MI, infarction, and ischemia.
Yeah.
If you look at a EKG, 12-lead EKG in a chart, make sure you know which ones to specifically look at. Because you only have like a few seconds, right, to look through the chart and all that kind of stuff. Figure this out in like 5 minutes. So make sure you can look at an EKG, test yourselves on it, and be able to look at what could be issues and problems. And if the patient knew about it, if they knew about it, they knew about it. I'm not too worried. Did they see cardiology? Yes. Did they have a stress test? Did I go to the follow-up? Yes or no? If they come into you and they go, okay, we gotta slow down. We gotta check something out. We have to see what's really going on before we decide to take them back. Yeah.
So I know with Dr. Pavlotti, we went over EKGs extensively. It's been went through, was it hypertrophy, was it, ischemia, injury? When you're quickly looking at it in those 5 minutes or less, which leads are you looking at? Do you care about hypertrophy? Do you, are you just looking for ischemia, infarction?
Most of the time that will already be done for you by the computer or the EKG, right? So you can, what leads would you want to look at? There's really 3 I'm thinking of mostly that you want to look at to focus on.
2 and V.
We don't know.
2 and V.
Depends on what you're looking for, right?
Yeah.
So what are you most concerned about? I'm most concerned about a previous MI, right?
Yeah.
Most, right? So what leads would I look at?
So you probably got to look at the base of the heart, right?
I think we need to go back and review that Dr. Pavlotti stuff. Say again?
Well, he had a whole list of, we're actually, interpreting the
Sure.
entire EKG, so that's why I was asking quickly, what are you looking at?
2, 3, and PFB.
B1 through B5.
Yeah, but B5, yes. And when you're monitoring them intra-op, 2 and B5, right?
Yeah.
So
That's what I.
which one's better for what?
B5 is better. If you're looking at hypertrophy, you want to look at B5,
Okay.
left ventricular
Function, basically. Yeah.
hypertrophy.
Yeah. Well, you can see ischemia, and like,
Yes.
because that's like the base of the heart, right? And you're getting a picture.
Ischemia there,
Yeah. Yeah. And
I
then
would say that most,
2 is like rhythm
yeah, it's
disturbance.
just like your basic rhythm.
Yeah,
You can interpret that basic rhythm.
Yeah.
Okay. So I'm trying to think of how to tell you. Okay.
Because you're only looking at the inferior of the heart if you're looking at 2, 3, and AVF. You got to look at the other side.
Well, perhaps the most common signs of infarction. I would like to look at that first.
Which would be what?
The LEDs, the RCM.
Those are the only 2, really.
Those are mostly the ones that.
Most of them happen inferior, right? So I think it's important to be able to look at an EKG and interpret an EKG. most of the time there will be, for an older person, there will be one that's there that's a baseline, and that will all have, if it was abnormal, it will have already been addressed. So if you look at it and it's abnormal, then you, well, where's the stress test, where's the echo, did you get a cardiac clearance? That's what I want to know, because I'm getting ready to go back, right? So that's really what I want to know.
Sure.
So you look at it, and you're looking at the different leads and go, and then you look at the little interpretation, that kind of helps you, right? And you go, okay. And what did your cardiologist say? Oh, well, I didn't see the cardiologist. Oh, well, when's the last time you had a catheterization? When's the last time you saw your cardiac doctor? What did they do? They just stress tested you. What did they say? They gave me a clean bill of health. Usually those guys that have had cardiac histories are going to have to see their cardiology to get clearance before they go to surgery, typically. And they're probably will have already done the EKG of the week before when they came in and did all the pre-op testing. And so if there was an issue in abnormal EKG and it was new for the first time, then they probably have already done that whole other process. So you're probably, most of the time, not going to catch something right there when you look at the EKG for the first time. But if it wasn't noted anywhere else and no one said anything about it, and you look at that and you go, wow, it looks like there might have been an issue here, an old one, it can't be determined, it always says that, cannot be determined, age undetermined. Then you can bring it to the, awareness of your CRNA or anesthesiologist. Go, hey, did you recognize this? I didn't see this anywhere else in the history. Did you realize that? And they go, oh yeah. What I ask the patient, what is your exercise tolerance? Are you able to walk? Are you able to do your daily living? I ask them if they can go up and down a flight of steps, and they go, oh yeah, no problem. I play soccer once a week. I'm thinking, you play soccer? But anyway, so exercise tolerance would really be what I want to know, regardless of what I see. Yeah. Did you have a heart attack? No, I didn't have a heart attack. And EKG said, you had a heart attack. But it's okay. What is your exercise tolerance? Now, have you seen a cardiologist? What did they say? If they had an abnormal EKG, there's probably going to be a test problem. But you're probably not going to diagnose them. We'll say that to a cardiac specialist, right? Okay, things to know. Increasing and decreasing parameters for each one of the body systems. But there's a couple I'm going to need to clarify as we go through. And that will be for your clarification. Everybody's really. So I'm glad you brought that up. Decreasing cardiac output, maximum heart rate, blood pressure, especially the diastolic. Sometimes it's up. Some of these parameters change slightly up or down, and some of them are kind of, they'll say, well, kind of unchanged, but maybe slightly up or slightly down. It's depends on what you do. But overall, these are the decreasing parameters. Increasing parameters. Heart gets bigger, stroke volume is going to increase. Why does the stroke volume increase? Yeah, it's a longer squeeze and a longer relaxation. So, what are the anesthesia implications? The margin of error is narrow. That's your take-home message, right? As a practitioner, the margin of error is real narrow because they just can't tolerate big changes. Higher blood pressures, they stroke out. Lower blood pressures, they start circling the drain ACLS protocols. High heart rate, can't hang. Low heart rate, can't hang. Any real change from their norm, they just can't do it. So for us, the things we do have to be thought out. We're probably going to use less of most things, and it's going to take longer for it to take effect. That's the main thing. We say this pre-op EKG is essential, but in some places, it's going to be different parameters for when they do it and when they don't. You guys know what they are? If you don't know, at the clinical site, that's a question to ask. You have an elderly patient, and the CRNA comes up and goes, what's the age that they give everyone an EKG? It might be 65. It might be 0 if they don't have a cardiac history. Or it might be anyone that's 70 and above. Or it might be anyone that's 75 and above. Sometimes it's arbitrary. So you have to know, it may be different at each site you go to, and you're going to go to 20 different sites, and oh my God, you got to figure it out. I know you will. My point is, you have to ask the question. Just because someone is 70 may or may not mean that it's required at that place. They don't have any, if they're not taking any medicines, and they're active, and they have good exercise tolerance, it may not be indicated. But it's a question to ask. I'm working with an elderly patient today. Is it standard for them to get an EKG here? Everyone that's elderly, and what age does that begin? All right. If they've had a history of MI, the chances of having issues and problems is much greater. They're more likely to have an MI intra-op. I've only seen probably 5 in my career, and I've probably done 10,000 cases probably. So it's not very common, but am I looking at the EK, am I looking at my monitor for that? Yes, I am. I'm looking for ischemia and MI every single time I'm looking at that. I'm also looking for heart block too. Actually, I'm looking for any changes that might be abnormal, but nothing scarier than to see, you know, 2nd degree or turn into 3rd degree, turn into asystole. Yeah, that stuff can happen, but it is pretty rare. The point is, if you know your patient's history, the chances are you'll be prepared for that, and you should be looking at it no matter what their history is, right? You're looking at the monitor, so you should be able to catch things pretty quickly. And if you catch things quickly and then you respond to them appropriately, you can save that person's life in a day and nobody else knew it but you. Thank you very much. That's what you do every day. Yeah.
So general question, I can imagine like the code or an arrest in a hospital room like we've seen as ICU nurses and such, but I don't know what that looks like in an OR. So I'm just curious.
It's pretty scary.
Drapes get torn, everybody move away, and then.
Well, it depends on where they are. If it's a big belly case, the surgeon's going to keep sewing while someone else is doing chest compressions. Now, your job will be airway, which you probably are, if it's a big belly, they're already intubated, right? So you're going to be pushing the ACLS drugs.
Okay.
That's going to be your job. So you're going to be doing the drugs, and some of you will be directing someone else to do CPR. You're coordinating with them. So if they're not, they won't be ventilated, you'll probably be bagging. So you'll be coordinating with them. You'll be pushing the drugs. I've had probably actually done, or I wasn't actually doing the CPR because I was doing the anesthesia part, but probably only 3 in my career. And I just delegated and I focused on my tasks, what was going on the monitor. So I reported to everybody what was going on. We just went to ACLS protocols. I keep a book in my bag, you know, because sometimes when you're freaking out, you just don't want to forget stuff. And how often do I do codes? Well, I've done 10,000 cases and I've done 3 or 5 codes in a 10-year period. I'm probably not that great, even though I take a class every 2 years, right? But I don't do it, right? I mean, I know the first few things to do, right? But once you get, you know, 10 minutes, 20 minutes, 30 minutes in, I'm like, oh, who's got another idea, right? So it's okay. It's okay to have
In my
your learning
experience,
aids.
it was really weird because, you know, I was used to ICU codes and I was the one that actually caught the monitor because it was a resident in there, and I'm the one that caught it, and I started doing compressions and all of the surgeons stood back and watched. So it's just me doing compressions and, you know, respiratory was handled by anesthesia, and finally we got other people in there, but it was the weirdest thing. You know, you're used to so many people in there.
I become the director,
So,
I am so laid back and I'm really not very bossy. You may not think that, but in my normal world. And so people don't know me that way, and so when I start getting authoritative, I go, you do this, you do this, you do this, and they do it, and it's really awesome. So I get really bossy, I tell them what to do and I tell them how to do it, and they're like, yes, ma'am, okay, it's great. But even that, I don't want to have those experiences very often, and you don't want it to be because you didn't catch something. So that whole thing about vigilance, it's so true. You gotta be paying attention. You gotta be paying attention. And these older folks, if something stressful happens on the other side of the drape, what would that mean? When you hear the surgeon go, oh shoot!
yeah, artery.
That's never a good sign because there's some kind of big blood vessel that they just poked a hole in, and now you're watching your monitor, you're opening up the fluid, you probably decrease the gas, you're like, okay, here we go. So blood loss could be a big one, right? Anything else you can think of that might happen?
Or even when they extract the bulk tumors, as soon as the big tumor is out.
They take, okay, you got this big old tumor that's been just getting all kinds of blood supply and everything, they take it out. What do you think might happen to the blood pressure? They also put pressure on organs when they're trying to do other stuff, especially like some of your teaching facilities. And you're like, everything's just great anesthesia plan, and everything's perfect. It's like, and then all of a sudden they're like, we're going into cardiac arrest. What's going on? oh, I'm sorry, my protractor like leaning on some, oh, I didn't mean to bend the aorta, I'm sorry. No, it's the vena cava. Oh, okay, but either way, I'm sorry. So you really have to pay attention to that. You have to talk to your surgeon when that's going on. One of the things you see most commonly, and whether it's older people or anybody having like any laparoscopic procedure, when they do the insufflation, the CO2, whenever I hear them say, you know, insufflation or whatever, I go, whoosh, and I look at the monitor, because usually you'll see the heart rate go from, you know, 70, 50, 30, who knows what. And I go, severe bradycardia, and for me, for every laparoscopic procedure, because it happens so often, relatively speaking, I always have 0.2 robenal drawn up in a 3cc syringe ready to go when I'm doing a laparoscopic case. Now, some days I don't have to use it, but I'll use it for when I reverse the patient. If I'm not using Geriatrics, but that's, I always have one ready, because when they say insufflate, they're putting all that pressure on the great vessels, and you know what? Oh, it's just, it takes your breath away, literally, when you first see it. You may have to request the CRNA that you leave the door for him to change your strums out to it. But it's really scary when you see it happen. It's dramatic, and it happens very quickly. So this week, it happened. I've been working with this surgeon a long time, and so I go, severe bradycardia again, Dr. Chapano. And so, you know, I give usually 0.2 robenal to increase the heart rate, and I usually give usually 10 of ephedrine typically. That's my typical MO when I see that happen. And it usually takes circulation time if it's an older person. And usually within 30 seconds or a minute or so, sometimes 2.
It's a long time.
I've never seen it go like from 30 to 25 to 0 on the insufflation.
Yeah.
They turn the pressure off immediately when I say severe bradycardia, and then I've already pushed the robenal I had ready and the ephedrine I had ready. And so in this, whatever the circulation time, then it usually comes, they usually come back within a minute or 2. But they stop everything they're doing until I say, okay, the heart rate's going up now. It's going up. So it went from 30, now it's 40. And I keep them posted like I'm doing with NFL code, right? Because they just want to get done. And I just want the patient to live. So I always tell them what's going on. And then, so I got the heart rate in a good place now. And I'm like, nope, we got to wait for this next pressure to cycle. Once it does and it's viable, I'm like, okay, we're ready. Okay, we're good. Then they go at a lower pressure, or they do it incrementally until they get to where they need, what they need to do the procedure as well. But it has happened so much to me. Now, the other things I say happens once every, 10,000 cases, 3 to 5 times when we have codes. This happens, I would say, once a month. I do a lot of general cases though, so I'm just telling you, be ready for it. You will see it, it will happen. All right, what else do I want to say? Okay, you already read about D5, the best one. Overall is lead 2. Respiratory changes. We have all kinds of issues related to what happen with these older folks. Their lungs are not as elastic, and this is something that's a process of aging. So it's not a comorbidity per se. It's not like emphysema or COPD or chronic bronchitis. It is just part of aging. So what happens is people's chest walls get real stiff. They get rigid. A lot of times their diaphragm, you know how your diaphragm kind of has almost like a flat bell kind of thing? It gets flat and it doesn't work as well. Your muscles and your muscle strength, the muscles between your ribs that help you breathe, aren't as strong. And so you have this kind of box that your lungs sit in. They actually, the lungs themselves, the compliance actually increases, but the cell wall compliance decreases. And I don't know if those two things are too conflicting to get. Do you know what I mean? So your chest wall compliance decreases. It doesn't move. It's not as flexible. It's not as elastic. You don't breathe as well mechanically. But your lungs can still do okay. But it's normal aging. Things happen. Things that decrease with age. I would know these. Mainly, your alveoli, which are the little ear sacs, they decrease, and the capillaries decrease. So you're not getting as good of oxygen and CO2 exchange, so the exchange is worse, and the alveoli aren't as elastic, so they're kind of like a balloon. You blow it up, and then it goes down. Blow it up, and then it goes down. Blow it up, and it goes down. But when you get older, they kind of stay distended, and so the air kind of hangs in there, so it doesn't leave as much. So the air kind of tends to stay in more because there's not as much elasticity there. But the actual, like, bronchioles can be, the bronchioles can work just fine, so the airways are open, but the actual exchange at the capillaries and alveoli have a problem exchanging the air. They just aren't as elastic. So normally, again, like a balloon goes in, goes out, it moves just nice and slow. Yeah.
Do you run them at like lower tidal volumes, like you're at that like 4 to 6 ml?
I usually do a
Okay.
little bit lower tidal volume, but I tend to be a lower tidal volume person anyway.
Well, because that's
Because I think the literature says that.
Yeah, that's
And then
the burden
also,
storm.
I add P
yeah,
to help.
5, 10.
Yeah, 4 or 5, it just depends. I
Okay.
usually don't go more than 5. Now, with some people that are showing evidence of problems with me ventilating them, I will go more.
Sure.
But usually I just do 4 or 5, typically, and that usually works.
Okay.
Yeah, typically. But again, muscle strength in your rib cage decrease. Oh, Lord. Another thing that happens a lot is the kyphosis. Have any of you done like a kyphoplasty? Yeah. So different places do those differently. We tend to put a tube in and use gas. Some places will do like a TIVA kind of a thing. Different places are different, and it's just, it's a prone case. And you've got this older person. So they first of all, you're going to go to sleep with them. They're on a stretcher. And then you're going to flip them over. And you get them on the bed, and you're going to put them in like a prone position, so their arms are going to be like this. But they may not bend this way. They may not bend this way. Their arms, if they were laying flat, their arms might not be. So you have to support them. So you have to use extra padding and make sure you put them in a position of comfort. And so I usually try to find out that initially. So if their arm is like this, and that's like for us this, you want to know that. Because it's not your job to go and help them out with that. Because you'll break something. Maybe not a bone, but maybe cartilage. Tissue holds everything together, so be aware of that. Also, because of the rigidity here, you have to think about that when you're putting them in a prone position. And I have heard of cases with elderly patients that were having a kyphoplasty, when they turned them over and just got them in a normal padded setup, they broke ribs. Now, you know those chest rolls that they have, they're like that gel stuff. It's really pretty soft, but it's supportive. And, they had like a dislocation of the xiphoid. What? And you're as gentle and as sweet and as kind as you can be. Or it's the same thing with skin tears. Their skin tends to be real fragile and things like that too, so you have to be super, super careful. We're talking about breathing. Oh. The main issue, key point, the alveoli are more distended at rest and not as and less distendable on inspiration. So again, they tend to just kind of stay here instead of going whoosh, whoosh. They just kind of go, they don't work as effectively. So that's going to end up causing like a VQ mismatch. Okay? It's got the capillaries all around those alveoli. It's going to cause some issues that may affect how they breathe. So here we go, minute ventilation. It changes. Oxygen consumption and CO2 production. Got a decreased metabolic rate. Now, this protective airway reflexes, coughing and swallowing tend to be prohibitive with older folks. Their oral airway secretions tend to be dry and less, but inside their tracheas tend to be more secretions, but they can't spit it out. Sorry about that. I was going to do a real one. So kind of get the difference between that. Oral airways will tend to be, when you see them, they tend to be dry. You know from my seat, right? Make the mouth, the oral airways, dry as a bone a lot of times. But inside, they tend to have more secretion. So that pulmonary, toileting kinds of things are going to be super important. The problem is because their muscles and everything aren't working as well, it's hard for them to get rid of those secretions. Whether they swallow or spit, it's hard for them to get rid of that. So all those secretions are just hanging there. What does that do for you in your airway? It makes it a lot more challenging for you to ventilate them appropriately. And it can cause bronchospasm, all those horrible things. So ventilation perfusion mismatch. Another thing that happens too with these closing capacity, you guys kind of get that? We're talking about the alveoli, right? There's a place where they're just going to crumble up. You need to have a certain amount of air or pressure in there to keep them open. And so there will be a point and a place where they just can't stay open anymore. That's kind of like the closing capacity, and it's reduced in older folks. But again, secretions orally is less, but tracheobronchial is greater. So know the difference between those two things. So orally, you're not even going to think about suctioning them, but you may have to suction them through the ET tube because there may be more secretions down there. You're going, I don't know what's going on. Well, you might have to suction them. Remember the old ICU days? You had to do that with the intubated patients. You may have to do that. You may not think about it, but you may have to do that more with some of the older folks. Some things that tend to be unchanged. Now, in some of the books you read, total lung capacity, they say unchanged or slightly reduced. Some of them will say reduced by 10%. So it's on the slide that says unchanged. Know that it can be unchanged, but it could be slightly reduced up to 10%. I know I wish I could just get all that, but no. So here are the key things related to respiratory changes. Total lung capacity, unchanged or decreased by 10%. Residual volume increases. That air gets trapped in there, right? Air tends to get trapped in there. Functional residual capacity decreases with restrictive disease. And what kind of stuff is restrictive?
Fibrosis.
Can't get air in, right?
Mm-hmm.
So I've got two answers for the same question. In an elderly patient, does the functional residual capacity increase or decrease? And your answer would be, it depends. If they have restrictive disease, decreases. If they have obstructive disease, it increases. What are some examples of obstructive disease?
COPD, asthma.
Vital capacity tends to decrease with age. All right. When we talk about the anesthetic part, it takes longer to go to sleep. It takes longer to wake up. Again, if you see the need to do higher FiO2, please do, because normally I do 50%, right? 1 air, medical air, 1 O2, 1 and 1. So I have 2 liters. Typically, if you're using desflurane, it'll be less. I usually do about 50%. These guys may need 60 or 70 or 100%. But I always adjust it incrementally. So I have 50%, it's not working, so then I go, first I usually go to 100% if I'm honest. I go to 100%, and it gets better. Now, oh, perfect. Then I start going down from 100 to 90. And I shift it to 70. I see when I go as low as I can, because I don't really like to have people on 100% O2 because that's not what they're going to breathe when they get extubated, right? It's going to be what?
21.
Yeah. So if I have to keep this person on 100%, I may not be able to extubate them at the end of this case. So if they start desatting and I increase the flows up to 100%, and then they start, their stats get better, and I slowly start weaning back down and see what they can tolerate. Usually, something's going on the inside that I can't diagnose in the moment, but if I give them the increase in O2 and it improves, I go, okay, this is good. And then I just start weaning them back down. They have some kind of moment that I don't know what it was, but now I've gone back to 50% and everything is good. Usually. But again, I recommend PEEP, and also because of these increased secretions, remember, not orally, inside, that you may have to do that pulmonary toilet, and you may have to actually suction the tube out more often too. Yep.
Do you put a Ballard on the internal suction catheter? Like, can you put it in line into
So
the ET
you
tube?
take, normally you have your circuit hooked up to your ET tube, right?
Yeah, absolutely.
And you're like, oh, you're desatting. I'm telling my little tricks, and I go, oh, that's not it, that's not it. Well, maybe they need to be suctioned. They didn't
Yeah.
burst me. So I take my little catheter, and I get it all set up and ready. So I have it hooked up to
Oh,
the-
so it's
to
old
the
school, old
suction.
school.
I
Okay.
take the catheter, I go, okay, ready, break. I
Yeah.
take it off, I put it in, and then I suction it, then I say, oh, maybe I'll do it again. If I had more secretion, I'll do it again.
Hmm.
And then I hook it back up.
And as though we used to do like with a trach.
Yeah.
Yeah. Okay.
Same concept.
Okay.
Now, to keep everything from alarming and stuff, you flip them over to the bag on the vent? Or will
You just
they
pause
alarms.
alarm?
You can do that. There's only one problem with that.
Remember to flip them back.
Yes.
Yeah. I might just pause alarms and just
I've
it
done
kinda,
it.
yeah. Oh yeah.
But
This
then
guy
if
right
you
here.
the alarms, here's what it was. Every time the alarm goes off, you are not the only one that hears it.
It's true.
We must have a student in the room, the surgeon says. Why would you say that, sir or ma'am? The alarm's going off a whole lot today.
Yeah.
So, what I do when alarms go off, I immediately, whatever I'm doing, which is usually charting, whatever I'm doing, I stop, I put it on pause, I see what the problem is, high blood pressure, low blood pressure, high heart rate, lower heart rate, whatever it is, I treat it, and then they respond, and the alarms are reset, everything's done. But if you just let it go, and then everyone in the room's going, my God, what's going on? Now, we all work together as a team to take good care of the patients. But that alarm is my business, and I don't want to alarm anybody else in the OR unless I need to. And if I do, they will know. I will tell them. But when the alarm goes off, put it on pause, address the issue. Usually it's a blood pressure. Typically low blood pressure, you're going to treat it with ephedrine, or heart rate's low, you're going to treat it with glycopyrrolate. You treat it, it goes back to normal in one cycle, the alarm's off. But please don't just let that thing go beep, 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 because then it becomes irritating, and they notice it. And then they're going to be worried, like, why aren't you doing your job? What's going on? Is my patient crashing? They're going to get all concerned about something that really they don't need to. Now, if the patient is crashing, you tell them immediately, right? But yeah, make sure you're aware of that. Don't ignore it, and have an ear for it, because you're going to be focused on tasks. At first, that's where you start. You're going to, what's my task? My first task, get them in the room, hook them up to the monitors, get ready for induction. You have all your drugs drawn up, we're going to do that. So then I'm doing this task, the sequence is this. You go to sleep, re-intubate, hook them up, turn the gas on, don't get turned the vent on, please. If the alarm goes off, what are you going to do? Look what it is, pause it, address it, take care of it. Don't let it go beep, 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 beep forever. Don't make friends, and you will get a lot of attention, but it won't be the kind you want. Now, I'm not saying turn the alarms off. Please don't hear me say that. Those are there to save you and the patient. Their life, your license. I see people that get tired of them and they turn them off. Don't ever do that. Now, you can change the parameters if you want to. You know, you can change the parameters within a few points, because this person's living in this place and it's alarming every second. It goes within this default place that you don't like. Okay, you can do that. Don't turn them off. Please don't turn them off. If someone you're working with does, that's on them. Don't worry about it. Don't say, Dr. Hartman said don't turn them on. Don't ever turn them off. I'm telling you not to turn them off. You're welcome. I know you're thinking later. All right, so what happens in the nervous system? Everything pretty much deteriorates with age. But function can go into 90 years old, 100 years old. Some people are completely with it mentally at that age. You need to assess that. Like again, my 95-year-old that I had this week, totally with it. I chose not to give her any benzodiazepine. She was totally with it, and I said, hey, do you want something for, well, I didn't even think I offered it, as a matter of fact. I said, how are you feeling? Are you relaxed? Of course, I said it that way. I didn't say, are you nervous? I said, are you relaxed? I said, you look very relaxed. She's relaxed. Okay, good. So I thought, I'm not going to give her anything. Took her back. For induction, I gave a larger dose of lidocaine as opposed to fentanyl. And so she went to sleep well. But again, small dose. That's why I used a 10 cc syringe instead of a 20 cc syringe for propofol. So I gave her a larger dose of lidocaine within her parameters. Instead of giving fentanyl, I used half the amount of lidocaine I might for a younger person, and took plenty of time to go to sleep. Went to sleep, intubated, had the procedure, got her breathing back on her own at the end of the case, titrated, and I think I gave her a total of 100 of fentanyl. Woke up in recovery, just as happy as could be. I said, I said, you look comfortable. Yes, I am. I'm so nice. Yes. And then for folks like that, older folks, I tend to order fentanyl in recovery as opposed to Dilaudid or something stronger. One reason is because right now we're out of Dilaudid at our facility, but also because I want something shorter acting. I would rather give them shorter acting drugs a little more often to keep their pain managed. And this is just my philosophy, then give them something longer acting, and then I gave them, it ended up being too much for them, and then I've got this other issue, I'm gonna have to re-intubate them because they went into respiratory distress, or they're not breathing on their own or something like that. So that's just my philosophy. There's lots of right ways to do it. I'm not saying I never, I do give long acting drugs to older folks. It just depends on what they're having done, but a lot of times I'll use other techniques. Like if there was a big belly case, I put them on, I'd use ERAS, I'd use a lidocaine drip, I might use magnesium. Even on a big case, I might only use like 100 fentanyl for the whole thing. It just depends. But lidocaine drips, I've been using them a lot lately, and they're pretty awesome. PACU doesn't like them because of the extensive PACU state, because they never like wake up and go, hey, I'm awake. They just are like comfortable. Just let them sleep. In our facility, we don't take the lidocaine drip to the floor, which I think would be helpful. But when people are on an ERAS protocol, then I think our PACU protocols need to change a little bit. Because the person can be completely stable and be comfortable, but still not be fully alert. But if they've had a big case, you want them kind of resting and comfortable. I don't know, some of those things still need to be worked out, I think, in our facility. All right, brain weight, oh my, another depressing number. Atrophy occurs. I noticed it already, but it started at 10, so I'm okay with it. Incrementally, it's not changed much. One thing that's important here is the opioid receptors, okay? They're going to decrease. There's a decrease in sensitivity to pain overall. So I'm very careful about what temperature I put the bear hugger on. It sounds silly, but you can easily burn someone because, again, their skin is very different and sometimes papery thin. And something that would be okay for a younger person to tolerate their skin, it can actually burn them. Or if you have the bear hugger where what's that called? The hose, the tube is laying on them, it can burn their skin. It seems unbelievable. How could that happen? I've seen skin get blistered from just having the tubing laying, like there was the bear hugger and then the tube was like laying on your arm. I saw blisters from that. And it was at like 43C, which is not uncommon for a bear hugger, right? But so just be very conscientious of that because older folks can't regulate the temperature very well. So something to be careful of. And as far as opioids go, they're very sensitive to our gases as well as narcotics that we give. Typically, you're going to decrease your MAC, and typically you're going to give less narcotics. That being said, whatever they're showing you hemodynamically, that's what you're basing it on, right? So some people, they drink a bottle of wine a day. They only have one glass. What is that? A big long straw in a bottle, right?
Yeah.
Okay, and they've been doing it for 50 years. All right, and they're 95. Perfect. But it may change my anesthetic. Their MAC, I'm thinking, I just have them at a normal elderly person's MAC, so it's a lower MAC, and I'm thinking, okay. And I'm like, why are they still wiggly? I don't know. Or when I go to induce them, I give, like 100 milligrams of propofol instead of 150 or 200, and they're still wiggly. And I'm like, did we have that conversation about them drinking? A lot of times I don't. It'll be on their sheet, and it'll say 1 glass of wine per day. And a lot of times when those folks tell me, I believe them. 1 glass of red wine a day. But I don't know what that means. There's like 5-ounce glass, there's like 10-ounce glass, there's like 20-ounce glass. Like I don't know. But sometimes you'll be amazed at what they can take, but typically they're going to need less of most things, and it's going to take longer for it to get there. Nerve conduction slows, cerebral blood flow decreases, but autoregulation is maintained. But you've got to stay within that 20% of your hypertension, your blood pressure, okay? But autoregulation is maintained. I like that. Circle Willis, baby, stays with you. What about if you're going to do regional, or you're going to do a spinal or epidural space? There's a narrowing of that space, the potential space, and the dura becomes more permeable because of the increased size of the arachnoid villi. Now remember all those things we did last semester, you know, skin, subcu, know those, and if you've forgotten those, review those. So if you're going to, in your head, be mentally prepared to do an epidural, be mentally prepared to do a spinal, because you may show up to clinical one of these days soon, and it's going to be your lucky day. You're going to get to do your first epidural, your first spinal, and it's going to be like, instead of being panicked, on your weekends, if you just have those little cards, like how to do an art line, read through it. It's going to take less than 5 minutes. Same thing with a central line, same thing with epidural steps, same thing with spinal steps. I like to learn visually and reading, so I would watch the YouTube, look at the steps, and then mentally walk through it myself. That's how I do it. And that way, when it happens to you, you won't all of a sudden like lose everything that you've ever learned and go white and pass out. You'll go, awesome, I'm ready. Yep. And especially if you know the night before. It may be a case, one of those kinds of cases, like let's say a total knee. Could be a spinal. Could be a fem sciatic block. Could be general anesthesia with an endotracheal tube paralysis, and the surgeon will do a pericapsular block when the knee's open. So you have to kind of prepare for all possibilities. So let's say you went to one clinical site and they did every single thing general with a tube, every knee, every total knee, general with a tube, paralysis. So I know how to do this, and so that's what you plan for. However, at the new facility that you're at, every single knee they use a spinal. And you're like, God, I haven't studied that for a long time. So if you're going to do a total knee, that's a great example. You do it. And then you go in and they go, it's general with a tracheal tube, no blocks. Okay, but I did review it. And the next time you review it again, you'll be ready. As far as thermal regulation, it is altered. Now, there's controversy about this less fat. Overall body fat is increased, but the sub-Q fat is decreased. Is that what you got out of your reading?
Yeah.
Okay. So is that clear? Because in this case, I'm saying less fat, but we must be talking about sub-Q fat. And does that make sense that that would affect the thermal regulation? Yeah.
So is there more visceral fat too?
Probably, yes.
So are we worried about that with excess uptake?
You could be, except a lot of times your MAC values are going to be lower, so it may not be. Yeah. But if you have, the way I look at it this way is,
But you have a greater
if it's an
volume
obese patient,
distribution.
I'm going to consider that factor as much as the geriatric. So if they're morbidly obese, then our weight would be a bigger deal. It would definitely. But this thermal regulation thing, you're going to do everything you can to keep them warm. They're still going to feel cold, but don't burn them. They could burn themselves in the shower by accident because they can't feel that it's warm enough for them. I'm getting there. You guys need a break? Or we're on just power through? Power through.
Yeah.
And something to look for is what their vision is like and what their hearing is like, so that you know their baseline. So if they have a hearing aid, they have to take it out and keep it in a safe place. If they have glasses, you leave it with the loved ones, keep it in a safe place. Because if they have dentures, you want to keep it with the loved ones, because all those things are expensive, and you or your anesthesia group is going to have to pay for it, or the hospital is going to have to pay for it because it's been lost under your care, perioperative setting. But I want to know baseline. I want to know what they were ahead of time, especially hard of hearing. I want to give that a report as well. Because they're going to take those things out, and the PECU nurse is going to be going, man, they just aren't responding. I'm like, that's because they're deaf without their hearing aid. So I tell them that. It's good information to know, right? So you want to be a kind nurse and pass that on to your nurse and report it back to you. If they have any kinds of problems with their brain, if they have dementia, a couple of your articles, they talked about that. MCI, what's that? Mild cognitive impairment. Now that is a natural process of aging, where the other one is PO, what is it?
CD.
Okay, what does that stand for?
Cognitive dysfunction.
And that is because of what we probably did, right? So anesthesia-related memory issues. So I want to know if this person has dementia. Well, you may not want to use it that's probably not how when I talk to a patient what I say. Now, if they list that they have it, yes, or their family members will tell you, great. I don't usually go up to someone's shoulder and go, do you have dementia? I usually say, do you have any problems with memory? Or, I ask them. They go, I don't remember. And I go, okay, well, I got that now. That makes sense. But I want to know where they're at cognitively as much as I can in those few short minutes that I see them. So that again, after the fact, I can give, when I give a report, I go, oh no, they were completely alert, they knew what was going on, they were totally with it. Yeah. And so if they aren't that way, then we might have a problem with some delirium. Now, I don't see that very often. I haven't seen that very often, a few times. And because of that, a lot of times the older people, like, gosh, doesn't seem that old anymore, but 85, 90, 95, I'm probably not going to give them benzodiazepines. I'm probably going to be very careful about what I give them because those things can definitely affect their cognitive function. And if they have a history based on what they tell me or their family tells me, then last time we had anesthesia, this is what happened. They wigged out. I don't know which one of the things that was given really caused it. But I do know that benzodiazepine and the opioids that we use, that they tend to be, and the gas that we use, they tend to be contributing factors. So I'm going to, if I can, devise a plan to work around those things or limit those things. Again, when we get ready to position them, I talked about sensation. I was asking, do you have any numbness or tingling, or do you have full sensation in your hands and your feet? Again, sometimes you go to put them on the bed and they're bent. They don't lie flat, like they're bent. And you go to you bend their back flat and their legs go up. You put their legs flat and their back comes up. So, and especially with their neck, make sure it's really, really supported. So they're going to be in a supine position. And you bring them over and there's the pillow and you lay them there and there's like this much space between their head and the pillow and you're not holding them. Support that. Double up the pillow or get padding or whatever you need to do. Because that is real common. Now, that is also a factor when you intubate someone, right? That range of motion with the neck. Whoa! You're hoping those people have upper and lower dentures. Because then you're going to have more space in there to manipulate the mouth open because their head is not going to be moving this way or this way or this way. It's kind of fixed. I find it disturbing when that happens because the wrong people that you are, even in the act of doing a DL, you might hear some cracking bones. And you can cause some serious issues. So just know how they are ahead of time and make sure it's documented. And then be as gentle. I know you're going to be gentle with everybody. I'm trusting that you are. But especially with folks that are older. You've just got to. Yes?
Do you think that the blade you use makes any difference? Of Mac over Miller being...
No, I think the finesse that the
interesting.
practitioner uses makes a difference. And always use the blade that you're most comfortable with. That being said, someone with a small mouth and a large tongue, and or either, both. I'm going to use a Miller blade. However, someone has a large mouth and a large tongue. I kind of like the curved blade because it has more, it's a bigger blade and you can move the tongue out of the way more. Where sometimes with a big tongue and a large mouth person, the Miller blade is so skinny that you lift up the epiglottis and the tongue goes like this around it. You kind of lose your view. So you'll learn these things. But my point, be gentle, really gentle, and make sure, like when you get them in that supine position because you're getting ready to intubate someone, make sure that their neck is fully supported because you will see that a lot. Part of it might be related to the kyphosis that they may have, and part of it's related because their neck is super rigid. But that affects your ability to intubate smoothly and easily. And anything you do, a small movement can mean a lot to them as far as causing issues and problems. So that would be somebody that I would probably use the McGrath or CMAP or glide scope with, because if I'm with a student particularly, we both can see what's on the screen, and it can be done. We can do slow, easy, and we're both seeing what's going on. We see the view. All right, that's good. And that's what I would use if I had someone that had a neck injury or we were keeping the neck in line. So I would use one of those devices then. And this is kind of the same thing, only it's a natural phenomenon. They don't have a neck bracing, but they kind of live that way. So you ask them to look up in the bed, and they go. You say, look to the right, they go. Look left. So that's your first clue. And so you're going to really cause a lot, you're going to do a lot of extra support there to make sure that they're secure. All right, regional. Yes, yes, yes. Sometimes it's not better, but it is something to always consider. CSF pressure is lower, the specific gravity is higher. The local anesthetic, when we put it in, may have a greater dispersion. Smaller doses for epidurals might be necessary. Now, that little space, that potential epidural space might be smaller. There's not as much. Slower emergence, circulation times increase, more sensitive to agents, temperature monitoring is essential. How would you like to measure the temperature? If I could, esophageal is a good idea, but what if we're doing a gastric sleeve? I'm not going to be able to put an esophageal in there because it's going to go in with the bougie. They give you that big bougie that's 38 or 40 French or whatever. You're putting that thing way over your shoulder, putting that thing in. You don't have room for all that stuff in there. So if they have a Foley in, you could do a bladder temp. You know, that is a way that people do it, but it really isn't. You kind of take an esophageal apart and do that. I can neither confirm nor deny that that is advised by the product manufacturer. But I've seen quote, yes, that is something that people do.
Well, they have the stickers on them, but
We do, and now how effective is a skin temp probe on someone that doesn't regulate your temperature very well? And well, I do that all the time. I do it. But I would say esophageal would be nice. If they have a Foley, just do a bladder. And the nasal is, if it's being used at the place that you're being used, yes, I think that's a good option. I use it when I was in the Army there, but I don't use it at all in the place I use where I work because nobody does, and if I did, it'd be gone. Here's the package insert. You're not supposed to do that. Okay, so I don't. But I do want to know what their temperature is. Something that I need to tell you. Be careful of when you tape their eyes, and if you use a skin probe, all those sticky things, when you pull those off, you can take the skin. I am as serious as a heart attack. And then you take the top layer of skin off that sensitive skin on their eyes, and it bleeds. Like you took the top layer of skin off, and it's bleeding. You know, like a skin tear. You know, I see nurses, right? It's like that, only here where you put the tape, or here where you put the temp probe, or here where you tape the tube. Please be very, very careful. Be gentle. Be careful when you take it off. You want those things you want their eyes closed to keep them lubricated, right? You need a temperature probe on. You need the tube secure, but don't just rip it off. You should do that with every patient. Be very kind and gentle when you take it off, but especially with these folks because their skin is compromised. And I have seen it, and I saw it recently, and it really was very disturbing for me because I feel like it could have been prevented. Now that being said, I've caused skin tears on older patients when I was an ICU nurse by accident, and I didn't mean to. Okay, I'm saying that, but please be conscientious of that because I've seen it happen just recently, so it's really dramatically in my mind right now. Okay, what happens to the kidneys? They slow down. Everything decreases basically. Renal mass decreases, the filtration rate decreases, the nephron size and how many decrease, the perfusion decreases. Oh, let's look forward to. So the sodium and water loss increase. There's a greater increase in potassium retention. drug elimination decreases. Anything that's going through the liver or the kidney is probably going to get eliminated more slowly. Same thing with lungs too. Now remember we talked about fat. Sub-Q fat is decreased, but overall percent body fat tends to increase. So if you see questions in your test related to fat, the question would be, are we talking about sub-Q? And we're going to say it would be less or loss. We're talking about overall percentage of body fat. We're going to say it would probably be, right? Good. Loss of body hair. All of these things contribute to loss of body heat. Thermoregulation is a real problem. All right. If someone's going to have an adverse drug reaction, 21% of the people that have those are over 70. Now that's strange, because I always thought it was like pediatric patients, because they're the first time people ever get drugs when they're kids, and if they have a reaction, they're going to have it when you first get it, when they're younger, right? But actually, they're more sensitive to having problems. So just be aware of that as well. The good news is a lot of times we're giving smaller doses of things, so I think somehow that's an advantage. And the problem is you wouldn't know till a little bit later because of that circulation time, right? Absorption it's problematic because of the GI tract, things get slower. Circulation is slow, we talked about that. Oh boy. I don't remember the last time I gave an IM injection to a patient. It must have been, I don't know, 15 years ago even. When I was a student, I had some CRNAs I worked with that asked me to do some like IM morphine, which I probably did. Now when I look back on it, that particular person was an inherent provider. It was probably water I was injecting them when they were probably doing something else. But I didn't know that at the time. Because I'm like, sure, would you do this? Would you give this IM injection to this patient? I said, sure. And I thought it was morphine, and now I wonder if it really was. And I looked at my other providers, and I asked my other preceptors as I went through my training, I go, how many of you give IM injections? Now, could it work? Sure, especially once it's longer acting. An IM injection would work. We always used to do it, right? I mean, we did it. But in the perioperative setting, we don't typically do it. And now I think about it, and I think, God, that particular person did one thing that was different than everybody else, and I wondered if I was, you know, yeah. Well, and I found out that person was, and but I didn't think it at the time. It was one of my preceptors, and so, but now I think about it and go, it may be a great technique, but because of that, I'm probably don't want to do it. But I think it is an option. And if I had more information and knew more CRNAs that did this on a regular basis, I might. But when I was an ICU nurse, actually not even, probably when I was a telemetry nurse or M-Surg, certain M-Surgers, I might have done IM medications, but in our setting, we have such better options. Alteration in distribution because of the body composition. Here we go. Fat content, total body weight increases. But the sub-Q fat, don't let that confuse you. I just saved you a couple of questions on the test. Oh, maybe I won't put it on there now that you know. Okay, lean body mass decreases. We know that. Albumin concentration decreases. And what? Oh, here's the bummer. Most drugs bind to albumin. So if you don't have as much there, and you give the drug, so you have a lower albumin concentration, what happens? You have more of the drug circulating around, which that's why we decrease the doses, because from their point of view, the percentage of drug that's available is great. Metabolic changes, we've got the hepatic blood flow changes. What else? Drugs need more time to be cleared because whether it's going from the kidneys or in the liver, also with breathing as well. So all those things are decreased. They all take long times. Getting rid of the drug takes longer. That might be part of the problem that we see delirium more in some of the older drugs. It's still hanging around longer than with most people. They've already excreted and it's already gone. Respiratory changes, decreased ventilation slows the rate of elimination of agents. We know that. MAC values are decreased, maybe even 20-25% as somebody gets older. With older folks, I always start low. Like normally, you intubate the patient, you're going to turn on the gas, right? What do you usually turn it on? You turn it on to 8, you turn it on to 2, you turn it on to 1. What do you turn it on?
What gas?
SIBO.
SIBO?
Good question.
Yeah.
What are you going to put it on? SIBO.
So are you going to overpressure? Like, I mean, you turn it up to like 6 and then turn it down to 2.
Intubated, and now we're going to start the case,
It was 6.
intubated, taped, I'm gonna turn a gas on, I'm gonna turn CO on, what am I gonna turn? You're gonna turn it goes up to 8, right?
Yeah.
I'm gonna turn it on to H.
Hmm.
What do you typically turn it up? I'm just saying. Oh, well, you're gonna have to know next week or next 2 weeks, right?
Well, if you're
Oh,
overpressure,
that's
you have
probably
to
a good
sit.
question to have now.
Yeah.
So, let's say you're using SIBO, you
Mhm.
intubated the patient successfully, congratulations. It may be the first or second time you've ever intubated someone successfully, I'm excited, I wish I'd be there with you, I'd jump up and down. The next thing is you gotta turn the gas on so they'll stay asleep, right?
Mhm.
So, I'm gonna turn the SIBO on, you have to press the button to turn it.
Right.
Don't forget that you just try to turn it, we'll lose some brownie points, but then you go push the button in, turn it, push the button in, turn it, what are you gonna turn it up to? It starts at like, I think it goes like 0.2, 0.4, 0.6, 0.8, 1, then 2, 3, 4, 5, up to 8.
Mhm.
What are you gonna turn it up?
6 is what I.
8? How many people say 8? How many people say 6? How many people say 4? How many people say 2?
That's where we want to
How
go.
many people do not know? Okay, every hand should be up.
Yeah,
Okay, all right. And the answer depends, right? It depends. You knew that was going to be the answer, right?
Yeah.
You wanted a number. But so what I would say, typically I'm going to put it on 2 or 3. If it's an older person, I'm going to only put it on 1, 1.5. Okay?
Yeah, the way the guys teach, you know, the short stuff guys, you know, they're like blast them first and then take them down, you know, because it needs to get in there.
I do not disagree with that.
Yeah, that's like
So,
everybody overpressures. Like Kelly, when you talked about inhale.
it's going to take a lot longer for it to get vibration.
Yeah. For like our target exhale would be like 1.5 for somebody that's old.
It's going to
Yeah,
take a
yeah.
long time for it to get there. However, with this particular population, and we're talking about elderly folks, I usually start them out kind of lower, and that's me because they can't handle a lot of fast change anyway.
Yeah,
Now,
I
a
guess they're
typical
good.
person,
Yeah.
I'm probably going to put it on 4 or 5. Like you guys, I'm going to take care of you in the yard. I'm going to put, well, you guys might put I know what you do on Friday afternoons after class. So, but no. Well, okay. So you get 4. But I would say typically I do 4 or 6. I would usually, I want it in there and I want it fast, so I want a high concentration, so I want to get it on there fast. With some of these, the older folks, I'm probably going to start them out low, just like I'm going to use 100 milligrams or 80 milligrams of propofol to go to sleep with. I'm probably going to start them out slow. So when I push the button and SIBO and I turn it on, I'm probably going to do 1.5 or 2. Now I don't disagree with the big concentration all at once to get it on board. But I also know that these guys aren't going to need it the same way as we would, okay? They're not. So I don't disagree with the crank it up and bring it on. I don't disagree with that. And I do it higher for younger folks, but for older folks, I do it more gradually, incrementally. Is it going to take a little longer? Yes, it's going to take forever longer.
Yeah.
Yep. But in my mind, it's going to be safer.
But like the probe should already be hanging around anyways, because it's
It
not
is.
like, yeah, because they're
It
not
already
hitting
is
rhythm.
hanging, it's hanging around, it's still there, it's
Yeah.
floating around.
Yeah.
Yes.
Yeah.
All right. I would know this slide about the pharmacological change. Mostly there's a delay in absorption and it's slower, basically, to get broken down and excreted, so it's slower to get on the drugs, it's slower to get off. Body fats, slows elimination. Body water content? So is there more or less overall water in older folks? Less. What about intravascular? Is it different? Compared to total body water, that's something probably you should have done. So.
Well, it depends on cardiac pressure.
It depends on really a lot of things.
Yeah.
But, a lot of times, I would say generally dehydration is what I'm thinking.
Yeah,
Typically,
big time.
both intravascularly and just in general. Typically, but it's not always the case. But again, when you start, you go, oh, this person's so dry, I'm just going to open up the fluid, I just let it roll in. I would not do a liter real fast. I would do it slow, gentle drip, Just like I would do a slow, gentle induction, just like I personally would do a slow thing with the CO, slow, that's me. Go ahead and work with Dr. Shore, just turn it up there. Go right ahead. Let me know how that works out for both of you. Oh, no. Hey, I won't. Maybe. I promise I won't.
They don't know it's me.
This is being recorded. Okay. One of the key take-home messages, your pre-op assessment is going to be essential. Get as much information as you can ahead of time. Make sure you know their cognition, hearing impairment, visual impairments, their ability to move their body, their range of motion, and their neck. You're going to have to over-pad or protect them in ways that you might not for other folks. Some of the stuff going on is related to their normal aging process. And does that make them an ASA higher because of the normal aging process? Not necessarily, okay? If it affects their functional ability, yes. So if I'm going to ask the main thing I want to know about their heart, what their exercise tolerance is. Main thing I want to know about their breathing, how well do they breathe? If they're not, they don't have COPD, emphysema, asthma, bronchitis. There's going to be some age-related changes that I have to be aware of, but they're probably going to be just fine. You listen to the lung sounds, if they sound good and clear, you're probably going to be fine. But be aware of the fact of these changes that you might have to change on a ventilator because they don't have as great wall compliance. So the main thing is you give your assessment based on the fact of where they come to you in their age. Now, there are people that are elderly that are in better shape than we are, cardiovascularly. Now, their heart might be thicker, but they can climb that mountain faster than I can in 2 seconds or less. Okay, they win. I hope that I can get there someday. That'd be nice. So the age itself does not mean they're an ASA 4. So if someone's 95, don't just make them an ASA 3 because they're 95. Now, I probably wouldn't make them an ASA 1 because of age-related changes, even if they weren't taking medicines. This can be argued among providers, but just because they're 95 and because of natural age-related changes, I would probably make them an ASA 2 if they didn't even take medicines and didn't have any diagnosis of any comorbidities. That's me, that's how I would do it. You'll have to find out what the CRNA is you're working with decides to do that. But I wouldn't make them an ASA 3 just because they're 95. They can still be happy and healthy, and if they don't have comorbidities, you don't really have to worry about it, but do be aware of these different anatomical and pathophysiological changes just on the aging process itself. If you add comorbidities to it, then you've got more things to consider. All right, make sure you just read through this just to make you aware, because you're probably going to be doing some of these kind of surgeries. I can't think of a place that doesn't do eye surgeries. So, have any of you seen these when you're observing? You'll get an opportunity to do these eye cases. So just make sure you read through that and the considerations are there in Miller. Postoperative complications, breathing problems, so atelectasis, because you already know those alveoli, they're not very elastic, so that breathing can be a problem. Pulmonary toilet, because inside the secretions are pretty great, even though outside they may not be, and they can't really cough and get rid of those. They can't control their airway, the upper airway as well. You want to get them moving, you want to get them hydrated, you want to do that pulmonary toileting kinds of things for them, incentive spirometry. If they're going to have issues, they might have heart issues because they probably already have a thickened heart, they already have delayed conduction, they already have issues just because of being older. So you want to make sure you watch for those. Any problem that comes up, you want to watch very closely, always, every patient. These folks, especially because when something shows up on the monitors, you have to treat it. Don't wait. You have to treat it and try not to overcompensate. Again, let's say their blood pressure, they start at 150. After induction, are you going to expect it to drop? Yes. Because you're going to turn on that SIBO probably to 2. maybe 8. See how that goes for them. Then the next pressure is like 60. And so then you're going to treat it. So their heart rate is normal. What would you probably give them? Oh, okay. You might give them ephedrine. If you gave them ephedrine, how much might you give them? 5 milligrams or maybe 10 milligrams. If you decided you wanted to give them phenylephrine, how much would you give them? 50 mics, 100 mics?
Yeah.
Okay, that
I
sounds
agree with
pretty
that.
reasonable. If their heart rate is low, let's say they're beta blocked, and so their heart rate's like 55, what would be your vasopressor of choice?
Ephedrine.
Ephedrine.
Yeah.
5 or 10 milligrams probably be a good choice. Again, if they were, let's say their heart rate was 80, the choice I would probably make would be phenylephrine. I would probably do a dose of 100 mics, that's me, but 50 mics would not be wrong, but you may have to redose it. And it depends on what the range was. If it was really 150 starting and then it was, what did I say, 60, then I would probably give 200 of phenylephrine. Just saying. But I think smaller increments are a better way to think as you're starting, because you can always give more if you need to. But if you give the wrong dose, if you give too much of a dose, you can't take it back. But you don't want to go from, again, let's say they went down from 150, let's say they went to 90, and so you gave, I don't know, let's just say 200 of phenylephrine, and then it went from that to 190. We don't want to cause a stroke. So I notice when I work with people that are newer or less experienced that a lot of times you will end up, you treat things and you kind of overcompensate here at this end, and then you go back over here and, oh, now I did this, so you got to overcompensate here. Eventually, you get pretty good at determining what the right amount of dose is based on the patient and what's going on with the patient. You'll get pretty good at that. But to start, I would say lower doses. And when you're working with a CRNA that says something different, please go with whatever they say when you're working with them. Make your day wonderful. But a general theory and rule of thumb would be lower doses more often, because you can manage that, control that a little bit better. Okay, watch out for MIs post-op, watch out for emboli. Overall, anatomy and physiology changes. Overall, your organ function decreases. Increased body fat, what are we talking about? Overall body fat, sub-Q decreases, and that's why you have problems with thermal regulation. Got it? All right, there's a reason I'm telling you this. Because everybody before in the past has always missed those questions on the test. I'm trying to help you out. That's why I should take that test question. Okay, decreased blood volume, decreased ability to retain heat, decreased lean body mass, decreased skin elasticity, collagen loss, decreased intracellular water. Whew. So, dehydrated. But when you rehydrate them, do it slowly and carefully. Everything slow, easy, take your time. Except, when you see hemodynamic changes, you don't want to sit back, you want to treat it. All right, cardiovascular changes, we talked about those. I don't know if there's anything new or different. Pulmonary changes. Here's the one I need to make sure you know. When we talk about, there's a decreased lung compliance, I'm talking about the chest wall rigidity, okay? Chest wall. Overall lung compliance actually increases, so make that note. Does that help? Okay. Overall lung compliance increases, but the chest wall lung compliance decreases. And then again, because of the pulmonary issues, and we're going to be talking about these all term with all the ages and types, population types, just make sure to review those slides so you have them kind of fresh in your mind. Again, just kind of review the EKG stuff just so you have it in your head. Don't think there's anything different in those. Nothing different in those. Risk for delirium postoperatively. Anyone over 70, if they have a history of delirium, I'm not giving them Versed, I'm not giving them ketamine. That's me. Many people still do those things. No judgment. Myself, I'm not. If they already have a history, then I'm not gonna do anything that I think might cause problems. If someone has a history of alcohol abuse, they're more likely to have delirium in the post-op area. If they have chronic pain and they're using opioids, they're more likely to have delirium. And if someone comes to you with depression, they're more likely to have delirium. So those are the people that are at higher risk. And you know the difference between MCI, just in case it has to be a test question, and postoperative cognitive dysfunction. Differentiate between those two, and if you saw questions about it, you could tell which one I was talking about, I hope. This is the slide that I think is really a nice, concise thing about what happens pharmacokinetics-wise. So I'd be aware of this. We know about these common coexisting diseases that we have to be aware of. I think that's all I really want to talk about. I had a case scenario where we were going to go over, but I'm okay not to, if you're okay not to. I think that's right. Is that true? Yes. Questions about this? I think I covered the things that, that seem to be somewhat contradictory in the past. Shoot me an email, I'll try to get back.